Okay, the mic's on.
Yes, yes, it's
Yeah.
working.
Yeah. I'm here with Leonie, my friend, mentor, and we need a bigger room for us.
So happy that you're here on the first day of IMCAS Asia. You were here last year too, right?
No, first time.
Oh, first time.
First time in.
Oh, you have no
Indonesia.
clue how long. I never realized he has to travel 2 times 10 hours, right?
It was
It's
a
a
day.
long, and only to be here with you. So this is about botulinum toxin and a little bit of ultrasound included.
Yep. And we'll get the show on the road. I don't know how to pronounce your last name. Natashat is going to do the first talk. Come on up. Precision pivoting. Solving the 5 common botulinum toxin injection errors with ultrasound. Perfect.
Okay, good afternoon, everyone. Welcome to Thailand. As a host country, I would like to welcome all of you. Okay. So today I'm going to share with you the topic about the precision pivot, solving 5 toxin pain points with ultrasound. As when you see your patient coming to your practice, usually you have to look through the skin and you have to understand that facial muscles is located differently in different area, right? But the main thing is that sometimes you see your patient's anatomy and you think of it like a 2D structure, but actually the muscle is like a 3D structure. You have to understand that each muscle has different depth, right? So you have to inject into the right plane, right level, so the toxin will go precisely into that area. But without ultrasound, you have to guess some time. But since you have ultrasound in your practice right now, you can visualize your muscle and you can target your muscle precisely. This is the ultrasound practice that I have in my hospital. We have a GE machine and we have a Clarius machine. And the GE machine, we have a linear probe and a hockey stick probe, okay? So how can we do toxin differently with ultrasound? I'm going to give you 5 toxin pain points that I try to convince you to use ultrasound in your practice. The first one is where to inject to avoid brow ptosis. So this is the ultrasound image of the forehead. You can see that the frontalis muscle is located quite deep under the skin. You can see the location, I will try to point. You can see the location of skin here, subcutaneous layer. This is the frontalis muscle, it's quite deep. So if you want to target toxin into the muscle, you need to go a little bit deeper than the skin. Sometimes you want to do like intradermal injection. That technique, you will not reach the muscle belly, right? And this is the convergence line. When you ask the patient to lift your brows up, you see that the frontalis muscle contracts to the central part of the forehead. And with ultrasound, you can use it to visualize the convergence line under sonographic evaluation. You can see that the frontalis muscle contracts toward the central part of the forehead. So the importance is that if you inject lower than convergence line, sometimes you may cause eyebrow ptosis. So you need to be careful. So last year I did a study at our hospital. We are going to publish the study right now, and I will show the prelim study result in Thai patient. We did ultrasound evaluation to see the depth of the frontalis muscle in Thai patient. You can see that the average depth of frontalis muscle in Thai patient is around 2.5 millimeter, and male patient has deeper frontalis depth comparing to female patient. And convergence line is around 3 centimeter above the eyebrow. So if you inject lower than average 3 centimeter, you need to be careful of causing eyebrow ptosis. Next one is crow's feet lines. Sometimes you inject and cause asymmetrical facial smile because of what? So I'm going to show you, this is the animation of patient giving you a big smile. You can see the contraction of orbicularis oculi muscle here. You can see the measurement, average measurement. You can see the depth of OO is very superficial, around only 1 or 2 millimeter. So if you inject too deep, you pass the muscle already, right? And from my study, you can see that the average depth of OO is differ between each point. As you go from medial to lateral, it's getting deeper. So if you're pointing your injection towards the lateral part, you need to go a little bit deeper comparing to medial part. And female patient has deeper depth of orbicularis oculi muscle. And this is a comparison between male and female patient. You can see that male patient has thicker muscle belly of OO comparing to female in every point. And you can see that OO is very close to origin of zygomaticus major muscle. So if you inject too deep and too inferior, you may reach the origin of zygomaticus major muscle. And that way it will cause facial asymmetry after injection. Next one is paradoxical bulging after masseter injection. We understand that it is caused by unequal diffusion of toxin due to DIT structure, right? So you have toxin, you have ultrasound, so you can do ultrasound guided correction, right? So during the correction technique, usually we can do it in plane or out of plane injection. For those who are not familiar, in plane injection, you will see the whole length of a needle because the probe and the needle is parallel to each other, and out of plane is perpendicular to each other, so you see just only a tiny dot of a needle. So in this case, you can see paradoxical bulging of masseter. You can see residual function of superficial part, which is circled in a red circle here. That is here. I'm going to show here. You can see the red circle here. This is the residual part of masseter that still functions. So in this case, I did out-of-plane toxin injection. You can see a small, tiny dot of needle. I deliver toxin to the residual part of masseter. You can see that we can use ultrasound to correct this complication as well. Next one is DAO injection. DAO is sometimes quite difficult to treat, and sometimes when you inject it blindly, sometimes it causes asymmetry because you're not injecting equal on both sides, right? So right now, if you have ultrasound in your practice, you can visualize DAO and you can measure a depth first. Where is the location of DAO? You can see this is the DAO muscle, which is located very close to DLI muscle. That is located quite deeper and more medially. And you can see that you can target DAO precisely and measure the depth from ultrasound. Like this. You can measure the depth of DAO, in this case, is around 6 millimeter. So you need to reach your needle quite a little bit deep to reach the DAO belly. Or you can even do ultrasound guided injection, like I show you here. You can see I try to visualize DAO and DLI here. And this is DAO under real-time ultrasound visualization. And I'm going to do in-plane toxin injection to DAO. You can see a whole length of a needle approaching DAO muscle belly, and I deliver toxin very precise into the muscle belly, like this. I do another side with the same technique. So that way, it will deliver toxin more precisely and change the way of your practice. Last one that I'm going to show you today is, in this case, asymmetrical crying faces. The patient come to me and she complained about when she smile, her smile is asymmetry. And even when she talks, she said that person that talk to her always looks at her mouth because it always like asymmetry like I show you here. So this condition is a hyperfunction of DAO and DLI on the left side. So I do ultrasound guide injection for her on these two muscles. You can see that this is a evaluation. I try to identify both muscle first. And I'm going to do in-plane injection into DLI muscle, 6 units of toxin. You can see toxin go directly into the muscle. And I also inject into the DAO muscle as well, here. You can see labiomental artery pulsating next to the DAO muscle, underneath the DAO muscle. And this is the result after. You can see that her smile is getting better, but when she tried to protrude her mouth, the muscle is still function, but she already satisfied the result. You can see that her smile looks more natural and more symmetry. So this is a 5 toxin pinpoint that I try to convince you today. You can use ultrasound to evaluate muscle anatomy before injection. You can see a depth of each muscle that you're going to treat, so you can treat it more precisely. And you can even do real-time ultrasound guided injection. and you can use ultrasound to correct complication that you cause. So thank you very much for your attention.
Thank you.
Okay, so I have to leave early because I have to host another room. Okay.
Oh, so we have a little bit of time. So if there is a specific question, anyone has a specific question for his presentation?
Oh,
No.
oh, okay, thank you
All
very
right.
much.
It was great.
you.
Thank you.
Thank you.
It overlaps mine a lot.
Oh, okay. So the next speaker is Dr. Steve Weiner. Yes. And he's going to talk about Botox complications.
Neuromodular. All right. It's great to see some familiar faces here. I'm going to talk about neurotoxin complications. And these are my disclosures. I do a lot with ultrasound, just like the previous speaker. And here's the problem with toxins. You're giving too much or too little, wrong location. You're not accounting for the spread, and I'll talk about that. And as the previous speaker discussed, the location of the muscle is very important. And I find that injecting superficially is easy, injecting deep is easy, but it's those intermediate muscles that are more difficult. And selecting the right patient is important too, or they're bound to have complications. So let's start with the periocular complications. And brow ptosis is probably one of the more common problems. And obviously it's caused by too much or selecting the wrong patient in the forehead, because the frontalis is the only elevator of the brows. So one thing that's very important is evaluate the muscles of the frontalis in the midline, because a lot of times the muscles don't fuse in the midline, and if you inject too much in the midline, you're going to get medial brow ptosis. So oftentimes when they have the frontalis doesn't fuse in the midline, I don't even inject the midline. First off, it could be wasted, but if there are a few fibers there, you end up with medial brow ptosis. The lateral corrugators must be injected very close to the brows or in the brows, or you're going to affect the frontalis, and I'll show you. And in general, keep your injections higher than 1.5 centimeters from the brow. So this is a study you guys need to look at, and what it was a Daxify study, and it was 4 different centers, and they found that one center had better outcomes than the other 4. And what did they find? They found that this was the injection pattern that they used, and basically it's the Proceris injection is near the medial canthal areas. The medial corrugators are near the inner brow area, and the lateral corrugators are very close, if not in the brow, to give the best results. And why is that? Well, Codofana did an MRI study, and all the blue is the frontalis. And you see that the frontalis goes all the way down to the level of the eyebrows. So anything when you're injecting above the eyebrows is going to affect the frontalis. And patients love elevation. Elevation is a sign of longevity and youthfulness. So be very careful about affecting any of the frontalis in your glabellar injections. Also look at the purple. The purple shows that the corrugator does not go above the brows. Okay, this is an interesting study from a colleague of mine, and they did quantitative analysis of injections in the frontalis. And what they basically concluded was that the more we inject the frontalis, the more likely the patient is going to have brow ptosis as they age. It is an aging process, but you're going to accelerate it with these injections. And if you inject the patients even early on in their 20s, they might have that onset sooner than if they didn't. So be careful when you inject the frontalis with low doses, and be careful in the younger patients. So this is a test that I do to see if they're actually a candidate. You have them close their eyes, you hold their brows, you tell them to open, and look at this patient. She automatically, subconsciously elevates her brows. Those patients are very poor candidates for injection because they need that brow elevation to keep their brows out of their eyes so that they can actually see well. There is one paper, maybe two, saying that you can inject saline to reverse toxin, and that's a fallacy. I won't go through it, but there was a computational model that disregarded that as well. Lid ptosis, this happens between 0.5 and 5. In my practice, it's very low, but it does occur. And it's caused by toxin going down the neurovascular bundle and weakening the levator of the eye. Dr. Kane, Michael Kane, if you know him, he advocates that this is mostly because it's unrecognized ptosis to begin with, and then you weaken the forehead and it becomes more evident. And in this case, take a look at the opposite side. You see there's elevation of the brow and more scalar show. That's the compensation. So this is a study, again, by Codafana that showed that in cadavers, there is some movement of the toxin through that neurovascular canal to cause this. And how do you treat it? Well, you can treat it with toxin in the pretarsal, and you do it on either side of the midline, just in the sub-Q, and that weakens the orbicularis oculi and elevates the brow by Mueller's muscle. You got to be careful. They can't close their eyes quite as much, so they could get dry eyes, so you need to use some drops if they're symptomatic. Oxymetazoline also causes elevation by activating Mueller's muscle. Diplopia, very rare problem, usually the lateral rectus because you're too close to the orbital rim, but you can also have spread vascular, and so the prevention is to stay at least 1 centimeter away from the orbital rim. Ectropion, I'm not a fan of injecting underneath the eye because of this problem. You can't really test it. You could do that snap test, but that really tests the skin integrity, not necessarily the muscle. The patient has lag ophthalmos. You do not inject underneath the eye. There's really no fix for this problem other than time. You could maybe put in some fillers. Dry eyes is a problem. The crow's feet close the eye and you're weakening that. You can also have spread into the lacrimal gland. And obviously if you inject the lower lid, they can't blink as well. So keep your injections superficial around the eye and do not over-tox around the eye. The treatment is lubricant. Malar edema can occur. Again, this is too much toxin around the eye. The normal pumping mechanism of the lymphatics is decreased. So a lot of people want to get rid of every last little wrinkle around the eye, and I'm not a fan of that with this microtox. It might be popular here. But this is what can occur, and you get this malar edema, and toxin usually lasts 3 or 4 months. This happens, and it can last a lot longer for some unknown reason. Bad tox usually lasts a lot longer than good tox. Here's my other reasoning why I don't do a lot of toxin around the eye. It's because the Duchenne smile, where you smile with your eyes, it makes you more, gives you the feeling of more satisfaction, more longevity, and perceived trustworthiness. Lower face, this was gone through by the last lecturer. The DLI and DAO are very close, and you can get, on this patient, it's the patient's left that is affected. And you can see by ultrasound, the DAO and DLI do overlap, so the spread is common. This is a paper by Codafana. If you don't have ultrasound, take a point halfway between the lateral the oral commissure and the jawline in the marionette, and you direct your needle towards the opposite earlobe at around a depth of 6 millimeters. And this is injection of the DAO. We've seen that just prior using ultrasound guidance. What do you do for it? I would do nothing. Some people advocate weakening the opposite side. The problem with that is that now when the first side gets better, probably the second side persists, so then you have the same problem. And then you also get food caught in your food gutter there. That's very difficult to improve. Some people do a little oxymetazoline on a cotton swab on the inside, and that gives temporary relief. Paradoxical muscle bulging, it was also gone over in the last lecture. It's caused by not injecting on either side of the DIT. Sometimes it's the deep, sometimes it's a superficial lobe. And this is the DIT, and it shows the two different lobes of the masseter. And this is the problem. The toxin does not diffuse through that DIT, so if you do it above, it's not going to go below, and vice versa. Rhizorius weakness, that rhizorius lies on the masseter, so if your injections aren't deep enough or more posterior enough, you can get the rhizorius. This is a problem that's very difficult to fix, or you can't fix it. And so Dr. Lee Walker recommended these safety guidelines. What I do is I ask the patient to clench their teeth. I put my finger on the anterior belly of the masseter, and I go 1 centimeter back, and I draw a line from the earlobe to the oral commissure, and I stay a centimeter below that. Tongue chin, it's with inadequate injections of the chin, and you just put more toxin in. Unusual reactions, nodular reactions, these are a spectrum of problems, and they could just be granulomas, or they could actually be infection. It could be a reaction to the albumin in the toxin. It's seen more in counterfeit toxin. It could be atypical TB. So there's not one treatment fits all for these. I've seen this about 5 times in my practice. This is an allergy to benzyl alcohol in the bacteriostatic saline. You get these nodules before they even leave the room, and you give them steroids either topically or IM or orally, and it goes away very quickly. You test it in the forearm. You test a little bacteriostatic saline in the forearm. If it's positive, then you mix your toxin with regular saline, and they do fine. Morphia, so these are like depressions after toxin. They're not sure exactly, but they think it's related to the silicon in the syringe. Some people inject a little saline, it gets better. Usually gets better on its own without any help. And one last complication is vascular occlusions. There are some in the literature, and their thought is twofold. One is perhaps it's the plug of the skin getting into the vessel. Others, it could be the rubber stopper plug getting into the vessel. You don't usually see necrosis, but you see impending necrosis and redness. There's no real good treatment. If you start injecting hyaluronidase, then you spread the toxin, but they usually get better on their own. Perhaps you can treat with hyperbaric oxygen therapy. The couple of patients I've been involved in, they had persistent redness which responded to laser therapy. And that's about it for me. That's how you get in contact. Thank you. Okay, we were on time.
Yes, we're on time.
Okay. Fontini Bajorzo. Injecting botulinum toxin by the book doesn't always give optimal results.
It's not like local name, but it's still very Greek for you.
Yeah, it is. Yes,
You know, in the previous room, we had like something.
there is, right there. I pushed it back. Sorry about that.
It should be like a radio. You will only hear us.
Yep.
So, hello everybody. I'm Dr. Bayorgu, coming all the way from Athens, Greece. And with botulinum toxin, the weird thing is we all know how to do it. With fillers, we try to find the best entry point. With toxin, we feel more relaxed. Yet, not all the time we have the result we want, aesthetic-wise, although sometimes the treatment is done by the book. So phasing aging involves a bunch of different things, and the mimetic muscles are giving us a lot of trouble, so we need to correct. And what we do is we try to improve the appearance of our patients. So let's say this patient came to our clinic to get improved, okay? He's beautiful, he's like handsome, he is. Not the ideal result we need to do. So we know that beauty lies in the eyes of the beholder, and these are some results. I'm pretty sure the injectors were really happy when these patients stepped in the clinic, but I'm not quite sure if they're still happy after the tabloids and all the publications in the news were looking like this, and there were rumors around. So getting back to basics, we have to understand and remember the two types of wrinkles we have on the faces, like the static and the dynamic, because this is not just theory, it's what we can promise to our patients, to what extent we can improve them. So the glabellar area is usually where we start from, and this is why we need to know the functional anatomy of the upper face, the elevators and the depressors. And here, the things are easy. We have one major elevator. We see a lot of different patterns for frontalis, but again, we have many different contraction patterns also for the glabellar area. And we just don't need to inject by heart, okay? Or because somebody showed us like here, and there. We need to know the anatomy, and we need to imagine what is happening in this complex of muscles. So we have the agonist, the depressor supercilii, and then we have an antagonist, the frontalis, and the part of orbicularis oculi muscles. Again, with the frontalis, this is easy again because all the muscles should rest in order to help the frontalis assist the movement. And we have a lot of individual variations for frontalis muscle. And this is why we need a very personalized protocol for all our patients. We have difference in the depth, we have asymmetry, the presence or not of bifurcation, difference between male and female, and this is what our patients look like, and why when we see these faces, we need to imagine our patients naked. By naked, I mean like that. So also, the crow's feet area has a lot of variations, and we have two types of orbicularis oculi muscles. We have this type that is pulling down the eyebrow, and the second type that is just giving us this curtain-like pattern of contraction. And this is, again, a different pattern of injection. Let's have a look at different patients and how the forces are evolving. You can see here forehead lines, okay, and you see that they aim to help to preserve the brow process, but you can see here how the dynamics change, okay? So we need to inject higher in order to avoid the complications that you just heard from our dear Stephen. So different combination of power. You can see here another pattern of injection. Again, different kind of forces. And this is the patient you don't want in the clinic because you have to inject low and you don't want to. This is a disaster. When I see this patient, I said, okay, why me? And this is a very nice publication. You have to go and read it. It's a big one, but to make long story short, they asked the big guys to inject the same area, and they had different kind of elevation. So then they asked for the injection points, and you can see that a tiny centimeter, like a 10 millimeter, can change completely the appearance of the patient. And why is that? Because we have overlap of the muscles. And a little bit of procerus has a little bit of frontalis, and a little bit of corrugator has a little bit of frontalis again, and this is why you have to be very, very precise with our toxin. So these are real patients from the clinic, okay? So we have to assess them in advance. What we see here, we can see an asymmetry, we can see it in advance. Nothing will happen for this patient if we don't notice, but you have to correct in the follow-up. So it's better if you give them a very nice result from the first time. You can see also there more lines, which means that we have a hyperactivity, which means that we need some more lines there, okay? And you can see also how broad the glabellar area is. So you need to do 3 injections, 5 or 7 in different patients. So this is the before, and this is the after. Again, very broad glabellar area. Maybe here we need 7 injection points. So not all the patients need just 3 or 5. You have to adjust accordingly. Male patients, with real big forehead. You can see that this patient has to be injected differently than me, that I have a little small tiny forehead. I don't know how to inject it. And this is the before, and this is the after. Patients with static lines, we should tell them that we don't need them in the clinic. No, we can still help them. We can still give them nice results. And look at this patient. Does it ring a bell? It's a mother and a daughter. So the daughter is coming in the clinic to be injecting because the mother didn't come on time. And you can see them, the genes are there, the same pattern of injection before, and here another mother and daughter. So daughters are proactive. Again, different patients. Look at this patient at the baseline. What we just heard in the previous lecture, some things are coexisting. So we have to pay attention before, because if we don't, look at what's going to happen there. So last patients, you see, young girl, contracting. Oh, what's happening here? Identical twins. And we can see that identical twins contract in different ways. So even identical twins need to be injected in a different way. Some food for thought, you know this publication, but it's always good to remember that the depth of the injection is very telling of what will happen. I don't like neither of the results, but it's very telling that we have to pay attention to the depth. Talking about the longevity and what is the best toxin, we can do the folds, and we can have pretty much the same result. Sometimes, if we add a lot of more units, what we take, saturation, so we know what happens if you double the dose or you triple the dose, it's published. The conversion line is here, and we need to respect it, and this is a very nice publication that will finish with that. You can see here we have a lady that has a history of right hemifacial spasm treated with botulinum toxin. So you can see here a significant muscle atrophy, including an hourglass deformity of the right temporalis. And why is this happening? We have a dramatic softening of the right nasolabial fold, secondary to this mid-face muscle attenuation, okay? So we have a pulling of a very weakened right orbicularis ocular muscle. So we inject our patients for years, so we have a little bit of atrophy. Some of it works for us, and some of it works against us. So since we're injecting people for many years, we need to keep this in the mind. So thank you so much, and keep in touch.
Thank you for that nice presentation. Oh, you're already here. Hello. Thank you so much. No, I'm happy you're here. Yes, thank you. And I'm also happy with your presentation, is how to prevent paradoxal mesenteric bulging. Welcome.
Okay, thank you so much. So good morning, good afternoon, good morning, good afternoon. I'm going to share my experience how to prevent paradoxical mesenteric bulging. So I've been using the ultrasound, facial ultrasound, for more than 10 years. So I encountered some interesting ultrasound findings. So among them, I believe the functional compartment, this concept is most important to understand the paradoxical mesenteric bulging. I wrote some books about clinical anatomy and ultrasound. I'm still active for publication. This is Korean data. As you can see, the Meseta is #1 indication for botulinum toxin injection in Korea. I think this is because the Korean beauty standards is different, because Korean women prefer very V-shaped, very slim face, so that's why the Botox injection to the Meseta is extremely popular in Korea. Interestingly, substantial patients continue to botulinum toxin for many years. Some patients are more than 10 years. So in the meantime, we think we need to understand the long-term changes of our Meseta muscle. This is a conventional injection point. Yeah, botulinum toxin masseter injection is really popular, but this conventional guideline has not changed for the past 20 years, even 20 years. Still, many practitioners still rely on the tactile feeling when clenching, and then some surface anatomy, and the 3 or 4 injection points. But this journal is almost 10 years ago, they published this journal. This journal suggests that what we believe may not always reflect in the real anatomy. So as you can see, there are very anatomical variations, especially parotid gland extends more to the masseter injection point, and the muscle thickness may differ. So sometimes we need more long needle to reach masseter fully enough. And then the others, so we need to consider about this. And in the meantime, I believe that ultrasound is very advantageous to evaluate the masseter muscle because ultrasound allows us to visualize real-time target and then the dynamic when during clenching or the rest, and then identifying the muscle and the ultrasound-guided injection or Doppler. So in the meantime, in real clinical practice, I think ultrasound is much more advantageous than a CT and MRI. So this is my experience. I started to use ultrasound. I performed ultrasound-guided masseter injection in 2014. So I've treated more than 3,000 patients. And then more importantly, the numbers of PMB or the asymmetrical smile is significantly reduced, almost rarely common. For the first, at first I told you that I encountered some interesting findings. One of them is first I want to share. This is a unique characteristics of masseter. It has deep tendinous structures inside the masseter muscles. We call it is deep inferior tendon. Deep inferior tendon, it has several types, but clinical perspective, I don't think that this type is really important. More importantly, it acts as a barrier, natural barrier, preventing toxin from the diffusing other side. As you can see, I'm injecting just above DIT, but it cannot diffuse in the deep side. But more important thing is, I think this is functional compartment because the masseter muscle is not a single muscle unit, and it has the 2 to 4 functional compartment unit. DIT is which is very the static structures, but the functional compartments is very dynamic. So which means that this functional compartments contract independently. So I think this is a key concept for understanding paradoxical masseter bridging. As you can see, this is conventional injection point. So it's focusing on in the middle part only. So if we use a conventional injection point, and some part may not be covered. And so in particular, this is the superficial part or the posterior part, anterior part easily missed. So in this missing, it can the risk of paradoxical masseter bridging. So this is these are some examples of functional compartments. It has we may observe sometimes 2 or 3 in the functional compartment. As you can see, when contracted, it looks different. So you can see the 3 functional compartments, and the second one is 3 functional compartments, but the part is different. And the third one is just 2 functional compartments. When we ask a patient contract, we can see the different functional compartments. So I think this is really important to understand this. And then now I want to share this real paradoxical masseter bridging cases. This is very simple. It looks very superficially. It is prominent bridging like this, but you can see that some superficial part of functional compartments are really active, while others remained very relaxed and weakened. These are more complicated functional compartment, the PMB cases. So this is very the male patient's very big masseter muscle. As you can see, and you see how the contract came. So At this time, we focus on the functional compartment unit. So, as you can see, so this when patient contract and this part is increased, which means hyperactive. So this posterior part and the anterior part as well. So which means that these patients have 3 or 4 functional compartments. I think these patients, the botulinum toxin is not enough for this big and hyperactive maseta. So I think that for these patients, not just some partial the injection. I think he needs, and overall the botulinum toxin is covered. And this is also my paper. And this is also interesting findings. After repeated botulinum toxin injection, the structural changes can be seen like this. Ultrasound allows to visualize these structural changes after the repeated botulinum toxin injections like this. So I think this is this is related to this fibrosis is related to the functional compartment, or after repeated botulinum toxin injection. Also, this fibrosis can change the functional compartment unit. Lately, I think this is deserves further the investigations. Nerve ending plate, it's also in the rehabilitation medicine or neurology, and it's almost proved like this. But there are some part, and the nerve ending exists where this is, we think, the maximum, the hypertrophic part. And then the thought band is usually found in the skeletal muscle, but in masseter muscle, I found this. Sometimes I try to inject, and I feel some local twitching on the masseter muscle. So I think this is this needs some further evaluations. So lastly, why paradoxical masseter bulging happens, and some parts are weakened, and others are still intact or is hyperactive. So that's why paradoxical masseter bulging happens. And ultrasound allows us to visualize and the structures like a deep inferior tendon or the functional compartment. Among them, masseter muscle contains 2 to 4 separate functional compartments. It moves independently. I think this is a key concept for the understanding of paradoxical masseter bulging. Also, we can think on the fibrotic change or the nerve ending plate or thought band, but whatever. I think this is we need to evaluate more. My message is very simple. Masseter is not a single muscle unit, and it contains 2 to 4 functional compartments contracted independently. I think this is a key concept to understand the paradoxical masseter bulging prevention and also the masseter muscle efficacy. Thank you.
I got one question for you. Have you looked at other muscles with fibrosis, specifically the frontalis? Because that seems to be a difficult muscle.
Frontalis, as you know, is very thin. In the insertion point, it is changes and fibrotic change also. So it's very hard to see the fibrotic change on the facial animation muscle. Right. But in the skeletal muscle, like a calf or the trapezius, I can easily see this is a fibrotic change. Whole the muscle fibrotic change, because I think that skeletal muscle doesn't have the DIT, so it's all single unit. So that's why we inject Botox, so it covers all of muscles, so easily.
So you got to assume that it happens in any muscle you inject.
Oh yes.
Yeah. So I mean that could be this pseudo resistance.
Yes, it is also related to resistance as well. But sometimes we misunderstand. Right. Oh, this can resist, but sometimes I realize that I repeatedly inject in the fibrotic side, which means the muscle atrophy side. So obviously this doesn't work as before. Mm-hmm. Okay, thank you.
Perfect, thank you.
Thank you.
Dr. Young Lee? Yep. Facial harmony with botulinum toxin, achieving natural balance and aesthetic proportion. Thank you.
I'm Dr. Young-Sub Lee from South Korea. Today I'm approaching a little bit different way because it's most the previous speaker talking about control the dynamic winkle, but is just focus about reduced winkles. But I'm more focused about 3D dimensional reshaping. Okay. So frontalis muscle dynamic is already some speaker explained about that. Frontalis muscle is primarily we think about eyebrow lifting, but it does not all. So its mechanism is more complex. So different region of forehead move different is direction during contraction of the frontalis muscle. So understanding this is a phenomenon as achieved is a natural outcome with botulinum toxin treatment. So is bidirectional the movement theory is C-line is anatomical observation is doctor is Sebastian and there is a colleague is demonstrated the forehead skin move is two opposing directional as movement. So upper forehead is moved to is cranial. Lower part is upper part is go down to the eyebrow. The lower part is make upward. So is intermittent. There is a convergence line. So I using that kind of mechanism to injection intramuscular or intradermally. So what is the C-line is clinically significant injection above the C-line is help migrate to the risk of the neuromuscular induced the eyebrow ptosis. That's why is C-line is very meaningful. This is a classical injection protocol. So this one only for treatment is winkles, forehead winkle is dynamic winkle. After that is a disappear winkle, but we evaluation of the skin is vector direction. So all of the skin, forehead skin is goes down. So is compare the before and after, we cannot recognize, we cannot check the preparatosis, but is all of the skin is go down. So patient's feeling is forehead is heaviness, even though uncomfortable. So this one is not recommend for all of you. Maybe our is proposed, our is target. After treatment, botulinum toxin, and then patient feeling is more optimized, more is a light forehead feeling, even though is more make a three-dimensional shape. I think that is better only inject, make a disappear winkle. So all of them is go down. So there is a C-line is already, maybe 3 speaker already is showed this one. So I try to 1 centimeter above the C-line, the injection. And another is the blue dot is the injection intradermally because I'm inventor for intradermal injection. So several times I explain about that. Simple idea is we inject botulinum toxin. Diffusion area skin is contraction immediately. So that's why I inject is lower C-line. That one is make a skin is a contraction. Also is a forehead, lesser depression. So after that, everything is goes to the is prominent and make wider. So I checked each of them. So first of all, inject 1 centimeter above. The low is frontalis muscle is okay, not any change. But upper part of the frontalis muscles, weakness of the depressed is contraction to the is eyebrow, so depression. So after that is like this one. Eventually is botulinum toxin is an injection. After that disappear is disappear or lesser contraction of the go down. This one is more comfortable to when we open eyes. Also, we try to intradermal injection, so make a contraction is low C-line. And then after that is C-line is disappear, the goes down contraction. This one is bulging, also is a widening. Because disappear to go down, is widening. So Caucasian is not necessary, but Asian, me also, is 1 to 2 more wider forehead. That case, we using like this idea, we can make more wider. So we evaluation. So this lady is even though Caucasian. So her is forehead convexity is okay. But after we treatment, modified injection technique is before is like this convexity, but after more convex, even though more wider. So we another one is whenever we inject botulinum toxin, forehead is what is the scary thing is preparatosis or like this samurai eyebrow, right? But is even though this case is we inject intramuscular in here and intradermal, after that is eyebrow is more is elevation. So is eyelid is more thin and wider. Big, when you open eyes, it's more bigger, right? This one is a kind of combination. So this is Korean lady. I try to same, but it's more wider, more convex. We evaluation of this, how much we wider, how much we projection. So evaluation with this 3D camera. This one is height is wider, okay? Usually is longer. So is before and after. Before is 31.71.3 millimeter, but after that it 34 point. So increased almost 2.3. So I tried to 5 cases evaluation. Preliminary observation is 5, but is first is mean increased 2.1 millimeter increased. This one is a evaluation with quantifier 3D camera. And then that case also, 5 case also, it does not happen any significantly. Brow is go down, brow is depressed, ptosis. So this one is another one. Because it's the first one we try to is wider. This one I want evaluation make a convexity. The evaluation of the how many millimeter is height. So is 2 different case also try and then make a evaluation. So this one also mean increase is 2.42 millimeter. Also is same 3D camera. And then also this case also it does not have any significant preparatosis. So injection a little bit different way, little bit modified. After that, we can make not only wrinkle disappear, also we can make a 3-dimensional reshaping. So traditional forehead approach is focus about the wrinkle reduction. But C-line guideline, the modified injection, of course, wrinkle reduction, even though potential is forehead shaping, so reshaping. Okay, so especially Asian, I also is forehead is very flat, right? Flat and narrow, but it does not 5 millimeter, 1 centimeter. But this one is projection convexity also is wider. General is a face shape is much better, much well harmony. That's why I introduced this one. So its finding is I summarized like it's because it's after injection is forehead is upper C-line, also is under C-line with injection intradermally, and then disappears down pressed upper is C-line is frontalis muscle function, is everything is elevation, also is more projection. So my conclusion and key takeaways message is respect to the C-line. C-line is very important. Also is a preserved low part frontalis muscle function and modified vector, not just wrinkle, achieved the 3-dimensional forehead reshaping. So that one eventually maintain natural brow is elevation. So from wrinkle reduction to forehead reshaping, injection of the C-line, we can make not only wrinkle, we can make also is a Thank you so much.
Thank you.
Thanks for our speakers staying on time.
Yes, also, all of us actually, up till now. So the next speaker is Dr. De Sequeira. Is that a good pronunciation? Oh, okay, almost, yes. And yes, Dr. Lucas, hello. So another talk which is very important is about resistance. So please go ahead.
Thank you. Good afternoon, everyone. Thank you for coming and watch me. Today we're going to be talking about a bit of a controversial topic, which is immunoresistance in botulinum toxin, a growing concern being overlooked by cosmetic practitioners. My name is Dr. Lucas. These are my open disclosures. I speak for multiple companies about multiple different products. And everything that I'm presenting is of my own here today. First of all, so to discuss about immunoresistance, we need to understand a little bit about the pharmacology of botulinum toxin. So the botulinum toxin is a protein that has two chains that have the light chain and the heavy chain. The heavy chain is responsible for binding to the presynaptic neuron and getting inside the neuron. And the light chain is the one that it's resistant, that it's responsible for promoting the cleavage of the snare proteins. Now, there are multiple different products in the market, right? So these are the ones that we have in Australia. I'm Australia-based. So there are multiple different products, and each one of them have their own little perks. They're all a little bit different, right? So, but there's one thing that is in common to all of them, that all of them need to have the core neurotoxin. And the core neurotoxin is the same for all of them, right? And if we just need the core neurotoxin, why do we need all the other stuff? So why don't we just make just the core neurotoxin? Well, we have the other stuff because they are what makes our products stable, that makes our products deliverable, reproducible, right? And we have complexing proteins, we have stabilizers, we have buffers, you know, like we have a lot of what we call excipients, right? To be able to make our toxins work, to bring the toxin to your clinic so you can actually apply it. So the core neurotoxin is a very fragile core toxin. So if it touches the walls of the vial, if it's shaken, if it's heated, everything will make it denaturate, and then we can't use it. It loses efficacy. So the excipients are other essential systems that, combined with the core neurotoxin, allow us to use it properly. But what is the problem with that? So the problem with that is the core neurotoxin for every botulinum A is not normally recognized by our immune system. Okay, like so it does not trigger an alarm response on our body. All right. Now, everything that we inject will cause an immune response. Our body will send our defense cells, and the defense cells are going to say, okay, this is harmless, let's leave it in peace, or, you know, like, this is dangerous, and let's get rid of it, you know, like, and then start producing antibodies and so on, right? So this can actually be very, very good. For example, if I'm introducing a protein that I want to be immunogenic, so I can produce vaccinations, right? But if we think that we can actually do the same thing with botulinum toxin, we're actually vaccinating our patients against botulinum toxin if we're triggering our danger result from our immune system. So it can be detrimental in that case because we can actually produce neutralizing antibodies. Antibodies will probably be created anyway, Okay, but there's different types of antibodies. There are binding antibodies which do not reduce the efficacy, and there's neutralizing antibodies that do reduce the efficacy of the product. Now, one of the big issues around, and I'm sure that many of you might disagree with me or so on, is there's always been a debate. Can botulinum toxin preparations cause that response and actually cause proper neutralizing antibody formation or not? Okay, and then there are going to be people that are going to say, no, this is, like a fairy tale, you don't have to worry about this, and there's going to be people that say, yes, it does, right? Now, one thing that I think that we need to be aware of is that there's debate up until the moment that we start getting scientific evidence showing that it happens, right? And now, when we do a literature review, and the reason that I've made that literature review is because similar to probably most of you, I had a case of a total non-responder, complete non-responder to every botulinum toxin. Guess what? I didn't report it. Like probably none of you have reported it. So it still becomes something that is like debated, but when we start having evidence that blood tests and samples were taken from patients and neutralizing antibodies were actually shown, then we start actually losing the capacity to discuss, is it real or is it not real? Okay, so some of these papers that I've shown actually show neutralizing antibodies on the blood that have been properly tested, and it shows the reduction over time. These are all published data and so on. So reduction over time until the patient actually becomes a responder again, right? So when we start having plenty of evidence, then that debate becomes a little bit futile, right? It's not like if it happens, it does happen. Now, we need to start investigating it more. We need to raise the awareness to understand why is it happening? What is triggering it? Is it the complex in proteins? Is it flagellin? Is it Clostridium DNA? What is it, right? So this is a case, and I wanted to show the case, so everyone understands why we're talking about this, right? So patient was treated with me since 2019. She used to come every 3 to 4 months, like every other patient, and these were the initial results. So for example, in 2019, obviously I did a little top up there because she still had some movement here. Yeah, that happens, like we were saying before, frontalis can be very tricky to treat, but you can clearly see that there is a response, right? So what happened with that patient is I kept treating her for a few years. And then in 2024, due to relocation, she started seeing a different practitioner. And in this case, I was treating her with abobotulinum toxin. So in February 2025, she returned to me saying, well, I think my practitioner is not putting the right dose, or I think my practitioner is not doing the right technique because I'm not getting the results that I was getting before, all right? And I said, great, it might be the case. So I treated her with abobotulinum toxin. Again, the same way that she has had treated and the same way that I had treated her before. And results were very poor, if anything, right? Then I said, well, something is happening here because I know that I put the right dose and I know that I put the same technique that has always worked, right? So then I said, maybe this is a case that you're developing antibodies. So what happened here is I changed and I tried 2 other different toxins that are supposed to be more purified toxins, to see if it worked. And surprise, surprise, it didn't. So she still had pretty much no response, okay? Showing that true resistance was happening in this case, all right? So a decision was made after I tried with 3 different toxins to interrupt her treatments and to say, okay, you were a true non-responder, okay? And that's when I started to say, okay, let's analyze the data, let's see if this is a thing or not, right? I'm currently trying to actually organize funding to have her bloods tested to show that, okay, she does have proper neutralizing antibodies. And then I started discussing with other practitioners, and everyone knows a case or two. You know, like everyone knows a case or two. But why are we reporting it? Why aren't we actually making this something that we have to recognize that there's clinical implications, right? There's, you can see some clients coming with dose creeps, you know, like we see patients that come more regularly and so on. Even though it's rare, it's normally under-recognized. We don't realize that it's happening until it's too late, and like that case, it stops responding altogether. So the treatments start becoming unreliable. We start sort of like blaming the practitioner, so like that my patient, you know, like saying my practitioner was the problem, right? And then it actually starts creating problems even for your business, you know, like for your reputation. But one of the biggest problems here is the ethical considerations. So if in medicine we always go for best practice, would you keep submitting your patient to a treatment that you know doesn't respond to something that doesn't work, right? So why would you keep doing that? And you're creating something that potentially, if your patient down the track has cervical dystonia or, you know, like any other therapeutic indications for botulinum toxin, it's not going to respond. But you created that because of cosmetic treatments, right? So why in medicine overall we have the best practice always to first do no harm, right? But with cosmetic, we may be forgetting about this, right? Using botulinum toxin every day, everywhere, and potentially causing immunoresistance that might even affect therapeutic results for a patient. This wouldn't be best practice. This is probably something that we need to take a little bit more serious. We need to start reporting our cases. We need to start sort of like trying to see like if we can get patients tested, you know, like so the discussion is no longer if it happens, but what are we going to do about it? I'll leave you with this. So let's raise some awareness and discuss about the immunogenicity that we might be creating for our patients. Thank you very much.
Thank you. Yeah. How many in the audience has patients with resistance? Yeah, I do. Yeah. Yeah, so about 30% or so.
Yeah, and how many of you have reported your cases?
Yeah, none. Yeah. One question. I talk about this too. Did that patient respond in other areas or complete, like glabella, or is it just the forehead?
Complete non-responder. So I treated sort of like the first treatment. I did a full-on treatment, no areas.
Right. Okay. Those people that raised your hand that have patients with resistance, was it all areas? Let's just say, was it all areas, or yes, or was there some areas like the forehead? I have some that have just forehead, and I think that that's a pseudo-resistance and not a immunologic resistance. Mm-hmm. Yeah, and so yeah, this is a problem. And the other thing is that we're starting to inject doses that approach therapeutic doses. Correct. When you start injecting masseters and calves and microtox of the neck.
Full face tox.
Yeah, so what these numbers are showing, mainly they're biased numbers because they're done by the company. Mm-hmm. And number two, they're only on label, which is lower doses than what we're doing aesthetically. So these numbers are much lower in the literature than what is real.
Yeah, I agree. And that's one of the things. I think that, you know, like especially after I started talking to other practitioners and realized that actually everyone knows a case or two, you know, like, so why aren't we doing something about it? Why aren't we discussing? Because it's only going to get worse because the treatments are only increasing.
You said you were going to send the testing for Germany. Is that the only
Yeah,
country
so
where they do
in
this?
Australia we can't do it. So as far as I'm aware, there's apparently only 2 centers that actually have the capacity to properly do the assays to test for neutralizing antibodies against the core neurotoxin. And apparently one is in the US and one is in Germany. At least that's what I sort of like saw.
One sub-note, on those patients, I have had a little success with using a little hyaluronidase with the toxin. And that's based on a study done by Dr. Goodman a long time ago that showed more effectiveness with your toxin when you added hyaluronidase. So it works mainly for those pseudo-resistant patients, very little on immunologic related, but it's worth a try. I had 15 to 30 units per the syringe per area. And so again, try the forehead, give it a go.
Yeah.
Because number one, it helps you if your injections aren't as accurate as you want to be, particularly in the forehead, it's tough. Number two, if there is a little bit of fibrosis, maybe it works around it. So, so give it a
Increase
try.
the dispersion or something.
Yeah.
Yeah. Well, I can talk to him. I'm from the same place as Goodman, so.
Yes, exactly.
Yeah. Well, thank you very much, guys.
Dr. Nadaporn. She's going to talk about LADD evolution, dropping the needles, the LADD evolution of botulinum toxin, for botulinum toxin.
Okay, good afternoon, everyone, and thank you for your kind introductions. I am Dr. Nataporn from Thailand, the dermatologist. I'm also the staff in the Dermatologic Training Center for the residency program as well. I know that Thai name is very hard to pronunciation. It's okay, so you can call me Dr. Nat. Okay, my topic now is about toxin. I have no conflict of interest in my presentations. And rather than the wrinkle treatments, nowadays we know that lots of evidences show that botulinum toxin is like a miracle drugs. You can use this for many indications, not only for the wrinkle treatments. So you can use this for the right eyes, and then after that you can use for the scar, and also for the rejuvenation, for the sebum control, for the enlarged port treatments. And nowadays we are all familiar with the toxin usage with only the injection with the needles. How about that? Because we can see that in some indications, the way that you use to treat is not put in the intramuscle. You need to put it intradermal for the skin rejuvenation and the enlarged port. And then for the intradermal techniques, the patient will have the pain and the bruises, and the most important problem is that the abnormal muscle movements. In the case that you really don't want to treat the muscles, the wrinkles. So how about the topical one? We all know that the topical cream of toxin, it doesn't work, right? Because usually the toxin cannot penetrate really into the skin. So with nowadays, we also have the laser and the technologies to help you to facilitate this toxin into the skin with the LADD. It's like laser-assisted drug derivation. The first thing that if you create the pores or the channels for the toxin to get inside, so it can work properly. However, the thing that you have to know that is about the safety. Is it safe to use the laser or any machines with your toxin treatments, and the efficacy of it, if it work or not, or it's just like to waste of the products, and of course the cost, because the cost will be more with the machines and the laser. In the size of the patients, not in the side of the business part. Okay. So let's start with the right eyes. With the right eyes that you can use for the wrinkles. We know that with the intradermal or intramuscle with the needle it works. And how about if we apply it on the skin? In this study, it showed that if you use fractional CO2 laser, and then you apply on one side, they apply on the upper pictures, they apply with the toxin, and you can see the results as it works. It also reduced the wrinkles compared to the normal saline on the control side at the below. In this study, they used botulinum toxin. And then about the scar. Let's see for the scar. In this study, they also use toxin compared to treat in the both hypertrophic scar and keloid scar. They use fractional CO2 as well, and then they apply the toxin. But the result is interesting because even the scar is different, the results are also different. In hypertrophic scar, on the LADD side, it looks to be better compared to the one on the keloid side. Maybe because of the keloid, they has a bit more fibrotic and a bit more thickness of the lesions. That's why the intralesional or the injection with the needles also can cause a benefit compared to the LADD. And about the hyperhidrosis. Because most of the patients, they're asking the toxin for the hyperhidrosis. And it's the very effective treatments. And at the axilla is fine. But how about on the hands? For the palmar hyperhidrosis, it's very, very painful. And the pain point is that because muscle here is very important for the quality of life, and with the skin on the palm is quite thick. Even you try to inject intradermally, but sometimes it's a bit too deep or it can diffuse into the muscles. So it can cause the patients to have the difficulty of the pinching, of the writing with your hand. So that's why this is Dr. Varapong here, so my mentor, he did a study at Siraj Hospital. He used the fractional CO2 laser, but in this study, he took 2 sessions of this, and then he applied incombrotin toxin. He chose this one because incombrotin toxin, doesn't have the protein complex, so the size of molecule is like smaller. So it seemed to be easier to penetrate down to the skin. And you can see that it can show the efficacy without injection this, and the complications is less compared to inject with the needles here on the palm. And for the skin rejuvenation, these studies they show that they use fractional CO2 laser and then they combine with the topical toxin on both sides of the face. Only one side use toxin, another side they apply saline, and they can see that for the hydration, for the erythema and the skin rejuvenation on the toxin side is better. It looks like that with this method. It also emphasizes the ability to enhance the function of the toxin as well. And the enlarged pores. Because the enlarged pores, I don't know that is that anyone used to use toxin for the enlarged pore here? It's very challenging because on the muscle, if you have to put it intradermally, you have to be careful with the facial movement of the muscles. So it needs the very precise depth of the injection to get the efficacy. So in this study, there is a comparison between intradermal and microneedling and apply with toxin. And in these studies, it looked like the results is comparable. So both of the treatment is also got the same effects. So I also did a study about this because for the enlarged pore, we know that the problem is that the enlarged pore has 2 factors. The intrinsic factors, that is the sebum production, and the outside factors, that is collagen around that. So if we can attack both of these, both of the sebum reduce and also enhance the collagen around that to wrap around the opening of the pores, can it be like the adjunctive effect of this one to treat the enlarged pore? So in this study, I compare to I use fractional CO2 laser on both sides of the face, but only on one side I apply toxin, and I also use incombrotin toxin. On another side, I use saline to apply on that with the same amount. And this study have the volunteer 15 patients. And this is a result. You can see that the efficacy will look better, and actually this one will be harder to look, but at 3 months the result is better. But both of them, you can see the volumes of both of them is better, and it's more obvious at 3 months after this. So if you want to compare of this, when we compare between on the toxin side and the sunlight side, you can see that on the toxin side, it has significant reduction of the pore volume at 3 months. But however, for the pore size and the sebum production, there is no significant. So but however, because laser-assisted drug delivery, I think it needs more than that. Not only for the first one, it's like the depth of the laser, and then the energy of the laser, and for the toxin, it can have different results with different dilutions and also the dosage of the toxin as well. However, I think it's like quite worth to study more on this field. So for the conclusion, for the safety, I think the safety is quite good because there is no reported of the muscle weakness. And however, in Asian patients, we have to be considerate about the post-inflammatory hyperpigmentation from laser. Because I think nowadays for the lasers that has more evidence for the laser-assisted drug delivery is CO2 laser, fractional CO2 laser, which is a problem for the dark skin types because they can get a loss of pH from here, and also the downtime from laser. But however, we can get the benefits from less muscle weakness in some areas. And for the efficacy, we can see that many papers that support that the efficacy is quite good. But however, as I told you that, the dosage and the dilution also to be concerned. And however, the thing that we need to study more is there any additional effects? Because in some treatment, the patient will benefit both from the toxin and from the machine at the same time, like cigar, like that. And however, I think the longevity of the outcome need to be studied more. And for the cost, because you know that when we apply on that, there will be some waste of the products for sure. And the patient need to pay additional costs from the laser and the machine that you combine with this. So I think these are the things that you need to be concerned and to consider before you choose the treatment for the patients. But I think it's like the new way, and I think there will be many, many more indications to use it, to use the toxin. So I think in a few years, these things will be the common things to do. Thank you.
Hold on, I got another study for you. Okay, a little variation. I'll give you a little background.
Yeah.
So I know some people inject at the same time they do lasers. I don't. So what happened is that I did an injection on a patient. She was from out of town. We talked about lasers, and then she comes the following day, 24 hours afterwards, and says, I want to do that laser that you talked about. It was a Fraxel, so it was non-ablative. Anyways, I thought 24 hours later, okay, I'll do it. I did it, and 3 days later, when she's in Alaska, I'm in Florida, she tears me a new one. She goes, take a look at me. And everywhere I injected was 3 times like worse, like the toxin was much more effective from that. But like I did the DAOs, she had a Joker smile. I mean, the corners of her mouth were way up here. And she looked horrible. So the thing is that I think that heat and whatever increase the efficacy of the toxin. So I would consider not topical, but injecting and laser compared to and see how that affects it. Does it give more longevity? Can you use less dose and so forth? Are there people here that inject and do lasers the same day? Yeah. Yeah. Okay. I'll show you the pictures. Okay.
Okay, so in your study, do you do the fractional CO2 laser and then you inject, or you apply like topically? The toxin?
No, I would suggest you do some type of study, combine lasers with injectables,
I see.
and see, because this did spread, and did last longer. One patient, N of 1, but I know some people do it simultaneously without any problems. You do? Yeah.
It's not possible that you just had a horrible day and
No, you got to see this. I can't show it publicly.
Yeah, because I also see that lots of paper that I show you, they also combine it with like no complications like that. Because at first I also consider about the heat of the machines that we affect with the toxin or not, because we sometimes ask the patient to avoid the heat, avoid the sauna or anything on that. But however, even with the micro needling, RF is also fine. So actually, I think the problems is still, I think about this is also you have to know, like for the machine, about the channel, the pores. I think everything also affect the efficacy and the complications. And with the injection, I think the complication can also happen with the intradermal injection. Like I told you, sometimes we try to do it at the very, very intradermally to make it safer. However, with the skin thickness and actually in some problems, they need the precisions of the depth to get efficacy, so I think it's easy to have the complications. Yeah. Okay, I will take a look at the pictures again. Yeah, but thank you for your sharing, I think. Yeah.
thank you.
Yeah.
Is there a microphone? There's a microphone.
It's not just question, because it's I a little bit answer about why during the combination it does not a problem, because safe, because we make lyophilized during lyophilized the liquid toxin make lyophilized, the temperature is over 60 degrees. So that's why is RF whatever is degree is under the 60. So that's why the combination it does not effective.
Thank you. Our last speaker for today is Dr. Ricky Smith, and you are going to talk about what is new. I'm very curious. Thank you.
Thank you very much. And I see they've brought in a nice step for the short people, which is quite nice. So I'm not going to talk about what is new on social media, Instagram, TikTok. I'm going to talk about what is new with publications and what is actually happening outside. So I'm from Pretoria, South Africa, so a very nice country to come and visit, and we are very scientific and very good medical regulations. And I've got a private practice and also involved at the university with as the faculty head for the advanced diploma in aesthetic medicine. For this presentation, it's totally scientific. I didn't receive any funding for it. So botulinum toxin remains one of the most popular treatments, but the demands from the patients is increasing. They want to do more, and they see a lot on social media. They're very educated. But the nice thing to know is that there's also a lot of research and development happening. And it's not just from companies, it's also independent research. Even on a lot of the very interesting topics that we've heard today, resistance, there's a lot of work being done on resistance. It's not like we're ignoring it and just keeping quiet. A lot of independent studies, there's also a lot of company-driven studies on resistance. The same on the combination together with the lasers, a lot of interesting studies. But I'm going to basically talk about three major things that I think is quite important for us in practice to know. So first of all is basically how we've had more precision-driven injection techniques. We've learned so much more about the anatomy, so we've actually mastered how exactly to inject to not cause complications. And then also quite new and trendy is a lot of patients are not chasing wrinkles anymore. And a lot of us doctors also, we don't want to treat the patient's wrinkles. We want to treat the patient to make them look better. So it's not just about freezing the face, but preserving the face and enhancing the beauty or attractiveness or maybe the tiredness of the face. And then there's also a lot of publications on microdosing or feathering, intradermal delivery, and also topical delivery. So a lot of interesting things actually happening in the development of toxins. So let's start with the first very important thing is anatomy. A lot has changed in how we actually treat the very basic indication, just for instance, the frown. For many other areas of the face, we've seen the very beautiful presentation on the masseters and how it's changed with the use of ultrasound. But what has changed is we've realized that we need to be very precise on anatomy, not just on static points, but the precise anatomy, the depth of injection, because it varies according to certain muscles, and the direction of the needle. It's not just these static points. These are all from package inserts from the companies. With just the little dots or the crosses, they are totally incorrect. The package inserts for most of the company products is incorrect, unless you really point the direction of the needle in a different direction. Because especially if we look at two major points where it's very incorrect, if we look at the medial corrugator, the medial corrugator is not up there, that's a frontalis. And this is why we're seeing so many Mr. Spocks, especially over the past few years, where there's an increase in use in toxin, is because we're dropping the medial brow, the lateral brow takes over, and then we have to drop the lateral brow also, and then the whole brow is dropped. Because we've not been injecting the medial corrugator, we've been injecting the frontalis muscle. So that's the first very important mistake, and these are from different registered products on the market, package inserts. So let's focus a little bit on the medial corrugator, because I think this is where the biggest mistake have been made for the past 20 years. And only being realized with very advanced cadaver studies, the use of ultrasound, and communications that is really going broad, and conferences, that we've realized we've been making a mistake by following the package insert. If we look at, for instance, cadaver anatomy, we can see the medial corrugator originates from the orbital rim, not 1 centimeter above the orbital rim, and that's how I was taught more than 20 years ago. I won't say how many years, then you can guess my age. So it starts underneath the superciliary arch. So the prominence that you feel on the bone, the medial corrugator is always underneath it. And then the corrugator travels up diagonally and goes through all the facial layers and ends up in the dermis. And that is 1 centimeter above the orbital rim. And that's quite important, because if we are following the injection points from the package insert, we are treating frontalis. So what does this imply? So if we take our 5 static points, they've been put a little bit lower just because it's different. The direction of the needle is going to determine where your toxin goes to. So if you're going to direct your needle upwards, then you're going to lower the brow. Sometimes you want to lower the brow, the medial brow is too high. But the direction really determines the spread, where it's going to spread to which muscle. So pointing the needle upwards in this way is going to drop the medial brow. If you decide you're going to rather point it towards the rest of the belly of the corrugator, you're also going to spread towards frontalis muscle, but you're going to drop a little bit more the medial part of the brow. If you're going to inject downwards towards the depressor supercilii and some of the orbicularis oculi fibers, you're going to elevate the brow. So there's a lot of changes that we know that the direction can actually determine the outcome that you want in the specific patient. And we need to know that you don't just statically point the needle in, you must decide which other muscles surrounding it do you want to affect and which ones do you not want to affect. So a lot more precision that has happened. This is an example video of a patient that really wanted elevation of the brow. She was saying really she wants a lifted brow because she's got upper eyelid skin that's bothering her. So here I'm treating the procerus muscle. I'm using a standard dilution of Botulinum toxin A, so it's 10 units per 0.05. And you can see I'm pointing the needle downwards towards depressor supercilii. This part, there's no levator palpebral muscle to be afraid of. I'm not going to cause eyelotosis, but the lateral corrugator insertion is where you can cause eyelotosis. So there you'll see it's a very superficial and pointing towards the belly of the corrugator muscle. Again, for this lateral point, if you're going to point it downwards, you're going to spread to the levator palpebral. If you're so afraid of eyelotosis, you point it upwards, you're going to get browtosis, because then you go to frontalis. So that really precision that we've seen developed in botulinum toxin, I think, is something very new. I'm going to just skip this one. Another place that we've realized we've been making quite a big mistake, for many years we've been treating bunny lines by saying we're treating nasalis muscle, which is totally incorrect because we're actually treating or targeting levator labii superioris alequenasi, which is the elevating muscle that starts from the medial lip going upwards. If you do treat nasalis by pointing your needle towards the center of the nose, then you can often cause a slight widening of the nose. Most patients don't want widening of the nose because remember the nasalis got two portions, transverse nasalis, which contracts and narrows the nose with very deep breathing, and the alar nasalis, which widens. This helps a lot for nasal breathing. So if you're going to treat transverse nasalis, you might affect that, especially in swimmers. You might really have a negative effect. And you're treating the wrong muscle. You're going to get a bit of an effect because gravity, and also it'll spread a little bit to levator labii superioris alequenasi, but this is the actual muscle that we want to treat, and we want to treat it in the direction of the muscle, not towards nasalis. We don't want to widen the nose, especially in African patients. They do not want to widen the nose, but pointing it towards the belly of the muscle, as you'll see moving downwards. So I think this has really significantly changed, that we are changing the direction of the needle. Frontalis, we've heard beautiful presentations, so I'm going to skip it because they've actually just confirmed and spoken a lot more. Then we have innovative techniques. We've just seen the presentation on the laser-assisted delivery, which I think is really interesting for those patients that you really want to focus on the skin surface texture and pore size. I think is a really interesting concept. But intradermal delivery also opens a very big wide field. And the microtoxin or mesotoxin or mesobotulinum toxin or whichever name you want to call it has got many publications around it. The publications are not just on tightening the skin and improving pores, but for rosacea, for acne, for flushing of the face, even facial hyperhidrosis, telangiectasia, other types of sebaceous hyperplasia. So there's a lot of publications, and it really is true. The tricky part with microtoxin intradermal delivery, as we've heard from the previous speaker, is the pain, the incorrect too deep injection, which is a very big problem because then it spreads to muscles with unwanted side effects, and bruising, which also means that you go too deep, you're not intradermal. So the technique is very important. So I'm just going to let these quickly run through. So this is just how I use microtoxin injections. So I put 50 units of abobotulinum toxin, or if you're going to use ONA or incobotulinum toxin, inside a vial of a skin quality enhancing product. I use the NCTF from Filmed. It's 3 milliliters of a polyrevitalizing solution. And then you have this magic fluid that they talk about, Glow Tox, or the magic liquid. Then your injection technique is very important. And this is where I want to get to the second part. So if you do intradermal delivery, it has to be like you treat hyperhidrosis axillary. If you're going to go too deep, you're going to spread to muscles, and you're not going to have the intradermal benefits. And it's very painful for the patient. So also there, we've got the option of maybe the laser-assisted, or we've got the option of maybe using tools that really helps us to give perfect intradermal. So this is a needle that's specifically made for intradermal. It was originally developed for vaccinations and also for insulin use in children. And it restricts you from going deeper than the dermis. And that also opens up something really new. So the other things that are new is on the formulation. So we get ready-to-use products that are already diluted, already available in certain markets. There's also a lot of research being done on extended duration, longer-acting toxins that will start entering the market, also shorter duration toxins. And initially, when I heard about those studies going on, you think, why shorter? And apparently there is a market for new users that want to try it and just have 1 month of effect and see what it would do. But that also opens up the whole debate of resistance, because that's quite important that we always respect that 3-month interval. And if we don't respect that, we can increase resistance. But there's also, as I said, new studies on resistance. They're talking a lot about the active toxin and inactive toxin. If you give more inactive toxin, you increase resistance. So a lot of new studies showing that. And that makes you realize maybe we shouldn't think about the protein that is added to the toxin as the enemy. The protein is actually there to protect the toxin. So a lot of new toxins also on the market. One important thing to remember, and I know that the speaker on the resistance also already spoke about it, as soon as we dilute the toxin inside the vial, it dissociates from the proteins and accessory excipients. Then we have the core 150 kilodalton. And this is quite important to remember. All the toxins will have the same amount of spread or diffusion after we've reconstituted. There's not a smaller molecule size that's going to penetrate deeper or that's going to spread more. Because as soon as you reconstitute it, the protein doesn't matter anymore. And also on that concept, a lot of the new studies have shown the protein really doesn't matter in resistance, because if you get those antibodies against the protein, there's no effect. Also, some really interesting studies have shown, not new, but quite a lot of patients with resistance to the 150 kilodalton, or not resistance, antibodies against the 150 kilodalton, more than 80% of them can still have a full response. And this has been shown in therapeutics. So also making us wonder, maybe just be careful to blame too much the antibodies and maybe look a little bit more at what you are actually doing in clinic, especially if you're not maybe delivering too much inactive toxin. This is a publication that compared how much picograms of 150 kilodalton is in the products that we are delivering. And this is something that we're going to hear a lot more about. It's not just units, but how many picograms are we giving our patients? Because this determines how potent the product is. If the product contains more picograms of toxin, it's going to last longer because you're giving more 150 kilodaltons. So this is also something that we'll see start surfacing a lot more in future products, in the way they market it, but also in the studies. But just as I said, remember there's no difference in spread or diffusion. That's very old marketing ways that they try to convince us to buy one product instead of another. There's no difference in spread between the different toxins. Then we also entering the era of new technologies, AI integration, ultrasound, 3D imaging and facial mapping, dynamic analysis. So I think we're really in an era where there's a lot of excitement happening. The way we're going to talk about toxins in the next 5 years is going to change a lot, not just to our patients, but even in studies and the products that we see. But we always have to keep in mind safety and best practices, to follow the consensus guidelines, not necessarily just the product, but consensus guidelines, to avoid complications by really following the recommended injection techniques, and very important, very accurate dilution and storage, because that's one of the biggest factors leading to more resistance, is inaccurate dilution and inaccurate storage, or counterfeit toxins with more inactive toxins leading to more resistance in the market. So I'm going to just skip to the conclusion, because that was on the topic that she's covered. I think we're seeing a lot of changes from our patients, a lot on the market. It also calls us to stay up to date with a lot of the publications, but it also gives us a lot of excitement in the field of aesthetic medicine to really know that it's always changing and always evolving, and that's why we need to stay up to date and attend all of these conferences. So with this, I would like to thank you. And we also have a wonderful IMCAS session at our Congress in South Africa, if you're interested to come and learn about complications. Thank you very much.
Again, I talk about resistance, and one of the things that I found was that intradermal injections are more immunogenic.
Yes.
Because
This has
of
been
the
shown, yes.
of the dendritic cells, they're antigen presenting, and so maybe not only the dosing but the location is increasing our resistance.
Yes, it's the same as with vaccinations. When they started changing vaccinations from intramuscular or subdermal to dermal, it elicited a better vaccination response. And with toxin, we also have to remember that if you're going to go intradermal, you might elicit a slightly higher increased risk of antibodies forming, but you also have to remember the intradermal injections will never last as long as your standard like glabella injections, so you can't retreat the patient every 2 or 3 months. You have to keep to your 4 or 5 months that you're doing all of the treatments. Also on resistance, which is interesting, is if you suspect a patient is resistant, you have to do an incident report. The company will help you then to also do the antibody tests because it falls into their responsibility. So it's not that you have to send them for the antibody test, but we're very lazy to do incident reports. Don't inject them with other products if you think there's resistance, because you're just going to revaccinate the patient and increase their resistance and increase the time that they need washout period. So don't go and try other toxins to see if the patient is also resistant. And that's very important to remember.
Yeah, I think it's a waste of time and money to start
Yes.
trying different brands.
And you're worsening the patient's case, yes.
Yes.
I just want to share a bit about the botulinum toxin resistance because my mentor, Professor Rangsima, she also had the studies about it, and at Siraj Hospital or here in Thailand, we can do the test for the toxin resistance. And then, but the point I want to show you that we can test that the thing that you resist to is the toxin itself or the protein complex. And it differs among the brands. So in case that if the patients, they have a problem that they resist to this brand, okay, we do that. And then if the patients, they resist to only the complex protein, they can use incobrin toxin, that it has not the protein complex. But if they really want to change the brand, they will benefit from tests from other brands as well, and to see that if they don't have that brand, they can use it. But if the patients really resist to the toxin, I think the only way to do that is that you have to stop the treatment and then wait for, I think, maybe at least 3 years. And then if you want to be sure, you have to make sure you have to repeat the test again, because we also can measure the quantity of the antibody.
Yeah, this washout period, though, has anyone had success with it?
No, in therapeutics, they've studied it a lot. It can be up to 3 years.
Yeah.
And in some of the therapeutic cases, they had to do plasmapheresis.
Right.
Yes.
Right, but here's the thing. I think that once you do it again, the antibodies wake up, so you get maybe 1 or 2 treatments, and then they're resistant again.
So I think if the ideal way is that you stop using the toxin for at least 3 years and then do the test again to see the titer.
No, but the antibody test doesn't guarantee a no result in patient. In therapeutics, it's been studied extensively because they use high dosages and they've got higher risk of antibody formation. So 80% of spastic paresis patients had antibodies but still had a full response. So it's not guaranteed if you've got antibodies against the 150 kilo Dalton toxin that you will not be a responder.
Yeah, I see that point, but at least if you have information, I think you can benefit from the data. But if you really want to do that, and maybe you can do it again, but you have to make sure that you also have the risk to that. You can, like, if you expose again, your titer of antibody can rise again. So you have to wait another 2 or 3 years, or maybe you don't have the way to do the toxin again. So
Dr. Dover wrote a paper that said that about 50% of patients that are, quote, resistant don't have neutralizing antibodies. So there's more to it than just the neutralizing antibodies. I agree with you completely about that spread. The difference is, though, that some have more non-active proteins, and those non-active proteins can act as an adjuvant. So like we do with vaccines, we give something to enhance the immune response. So the more, you notice that the newer toxins don't have, they're naked. They don't have.
Yes, but there's a very
complex
good publication called Is Proteins the Enemy? It's a very complicated publication, but it explains actually that the proteins is actually helping us to have less inactive toxin, because a protein, if you think of botulism, the protein actually protects the toxin. And now the newer studies are showing the highest risk for antibodies is inactive toxin. So meaning that you probably didn't keep it in the fridge correctly, or your nurse left it outside, or you used a product with not protein and they've got more inactive toxins, and then the counterfeit products have got the highest risk of, because they've got a lot of inactive toxin. And that's exactly what they do in vaccination, is they give you inactivated toxin. So inactivated botulinum toxin is going to elicit the most immunogenic response. It's very interesting.
I guess it's because it's not incorporated into the neuro end plate. It just sticks around.
Yes.
That would make
And that's
sense.
vaccination.
That would make
Yes.
sense. Yeah. Okay. Are there questions from the audience? We have around 10 minutes. Do you have any questions? Do you? Let me just reference the study that I did with Greg Goodman and with hyaluronidase. What he did was he was scared of using hyaluronidase in the face, so he did it in a hyperhidrosis patient. And what he found was that he gave 25 units of toxin, and he used hyaluronidase on one side, and used 50 on the other without the hyaluronidase. He found both sides were equal effect, and he used galvanometry with that. And so I think that hyaluronidase makes your toxin a little more effective. It can squeeze through maybe the fibrosis a little bit, and it also at the neuro end plates, there's a lot of hyaluronic acid that protects the neuro end plate. So maybe it helps get the toxin into the neuro end plate. So theoretically, you might be injecting hyaluronidase with your normal patients to get more efficacy. It's potential. But maybe you're going to create more resistance too. So who knows? I give between 15 and 30 units per area, and I add it to the syringe. And
I know they're studying it for hyperhidrosis, but I would just be cautious for the lateral corrugator point. And DAO, I wouldn't want to use hyaluronidase.
I agree with you. In those cases, I'm injecting more concentrated solutions.
Yes.
I haven't had any complications, knock on wood.
Yes.
Yeah.
Thank you very much. In your study with Dr. Goodman, was the duration of effect the same on both sides, or just the initial response?
I don't think it was printed how long it lasted.
Thank you.
Yeah. But I do, and again, I have some patients where the forehead is the problem. Good responses very well, and I do think it has something to do with fibrosis, and these patients, it's a godsend for them.
I forgot the number, but there was a questionnaire done at IMCAS Brazil, I think, in the last year, and they asked everyone what you have, the forehead, if there was a certain area of non-responding, and that was huge, but I forgot the number, but I think it was like, I don't know, 20, 30%. It was really huge. But that's more fibrosis, or you cannot say fibrosis until we did histology, right? But there's something going on.
Yeah, I think the frontalis is a very thin muscle, so it wouldn't take much fibrosis to affect it. Yeah. Any other questions? No? Okay. Yeah, I guess that's good.